All right, we are back again, and this time too is on the same pelvic inflammatory disorders. And then quickly we are going to stick to this one, which I circled first that we are not going to talk about it. So, I mean, we have now got into it, so let's get straight into it. Now, I ended the last episode with something where I was saying that if we get to manage it or we get to be given all the necessary medications and then the duration to be taken, and then we do all of that, why do we still stand a chance, or how would someone stand a chance of being or contracting the disorder again or the disease again? Beginning, I spoke about the fact that this is a sexually transmitted infections in females, right? It's caused by Neisseria, that's the organism that causes gonorrhea, chlamydia, and then mycoplasma. And I earlier even also spoke about the fact that other organisms can come in, like the E. coli, anaerobes, and then streptococcus, and then other organisms as well. And then I hinted on the fact that these three organisms here are the main cause. They cause about 85% of the these particular conditions. You understand? So if you are going to give a treatment, your treatment is basically or should basically focus on what, dealing with these three. To a point, even when you do your, even if you are supposed to do your cultures and everything, and you still don't find these ones there, your treatment should focus on them. You need to assume that they are there, because 80% of the cases, these are the things there. These are the things causing the havoc. These are the things causing all the discomfort at the upper genital tract of the female. All right, so your major treatment, these are bacteria. So basically, you have to deal with antibiotics. And then yes, so the treatment, we can go parenteral, that's we can go injections, we can go inside the person's vessels and push the medication there, or we can decide to say, okay, let's tackle these things with orals if the person can tolerate them. Because there have been points where people suffer from PID to a very severe point, they get to have these systemic symptoms like fever, vomiting, a whole lot. You understand? So within those type of patients, you wouldn't want to go oral because they may not be able to tolerate. So you would want to go parenteral, that is injectables. So regardless of the side you would want to go, you need to tackle these things. You understand? I don't want to go into the mechanisms of the medications here to bore you. I didn't come here to bore you. I just want you to understand. Now, one major thing you need to understand that any of the routes you are taking, make sure that if you are going to the parenteral route and you do your parenteral route for maybe 2 days or 1 day, let's say maximum you want to do the injections for 2 days and continue with orals. Whichever oral you are going to choose or medication you are going to choose, the person should at least take the medication for 14 days or 2 weeks. Whichever medication you are going to choose, just take it like the person or the patient should take the medications for 14 days. And these are the various options. Let's say we are going through the parental route. I mean, yes, it's good at all. We have injectable doxycycline. So this is ceftriaxone, this is metronidazole, this is doxycycline. We have all of them injectable. Just that doxycycline injectables is not common in our part of the world, but then we have, and mostly the bioavailability of, that's the amount of the content, the concentration that gets into circulation to work, either is injectable or this one is basically almost the same. You understand? The effect is almost the same, but then the injectable is not common. So you have ceftriaxone, you have metronidazole, you have doxycycline. You can use them. This, like I said, I'm not going to bore you with the mechanism. This is a cephalosporins. This is a cephalosporin. This is an azole. This is so what happens is that we have, when you come to the cephalosporin side, we have other options you can use. Just that those are the first generation. You can use the first generation and then the second generation as well. But then these are not common. You understand? These are not the second generation. The first generation you can use them. That's Cefotetan and those you can use them, but then those are not readily available. You can use ceftriaxone, metronidazole, doxycycline. You can decide to go the injectables for the first 1-2 days, then you switch to orals for the person, which will last for what, 14 days. Then you can have alternatives as well. You can decide to do cleaner and gentamicin. I mean, when you are doing cleaner and gentamicin, you are looking at the toxicity level, the nephrotoxicity, basically, yeah, the autotoxicity, and those. You are looking at those things. But then, I mean, if in a situations in a setting where you need to go in for them, you can as much as do clindamycin 900 milligram QID for the person, and then go with what the gentamicin in addition as well. So when you are done, you switch the person to oral. Then you can have ampicillin sulbactam and combination and with what doxycycline. Then you can also have azithromycin, metronidazole. I mean, we will talk about azithromycin. We will talk about it when we are done. When to use it, we will talk about it. You see that blue thing I've done there? Yes, it's with azithromycin. So you can do azithromycin and metronidazole. Please let me chip in this. It's recently I was also told the fact that azithromycin comes in 3 tablets doesn't mean every condition you are treating is the person should take it for 3 days. No, it doesn't work like that. The fact that azithromycin comes in 3 tablets doesn't mean that the condition you are treating, if you want to use azithromycin, the person should take azithromycin for 3 days. It doesn't work that way. So, I mean, more example. Let me give, if I give you a scenario, you come to understand. We have fluconazole that comes in 1 tablet form or 1 capsule form. Does it mean if you want to treat a condition where the person has to take fluconazole for 5 days, you can't do it because it comes in 1 tablet? The same way that can AL, artemether lumefantrine, comes in either 6 tablets or what. You take it for 3 days. Does it mean that if you treat and there is failure, you won't give the medication again? You understand? So all of these things should be considered. It's the duration of treatment you are supposed to give, not the the half-life of the drug. Azithromycin has a very long half-life. It can be like, I think one will last for about 72 hours, and then it will just be in your system releasing its effect. But at the end of the day, that's not what we are looking at. We are looking at the properties of the organism that is causing the disease as well, to come out with a regimen to be used. So the fact that it comes in 1 to 3 tablets doesn't mean that the person is a person who is suffering from PID should take it for 3 days. It will not work. And these are some of the reasons why resistance is small. Alright, so if you want to treat the person on OPD basis too, you can go the IM ceftriaxone 500 milligrams stack. Then you can attach it to doxycycline and what metronidazole for 14 good days. Then you are done. And the last thing I want to chip in, when it comes to the azithromycin doesn't work for Neisseria. So before you choose to do azithromycin, basically you are supposed to rule out that Neisseria is not the likely cause of the PID you are dealing with. And it's hard to do that. It's very hard to do that. But then probably you have to do a culture. But one of the things is that before you use azithromycin, you should just take note of that. The Neisseria is not the likely cause of what the person is going through. Alright, so let's come to the reoccurrence. When you do all of this for the patient who you have to be your clients, and then you've been able to get through all of this, you've been able to achieve your goal, get rid of the condition of the disease, of the agent, how do you prevent the person from not getting it again? You go straight to the partner. You can have what we call patient-delivered partner therapy, where you prescribe the medications for the patient to send it to his or a partner for it to be what? For it to be taken. We can't trust patients like that. So sometimes you have to let them bring their partners. Then you advise them. If you tend to have multiple partners, please, we have to. You need to tell us the truth. Then we can maybe call all of them and have a discussion with them one after the other. Or better still, you can use a barrier method when you are going to play around. You understand? So what the most effective preventive measure is using a barrier method when you want to play around. Just use a barrier, especially for those who have multiple sexual partners, in order not to be suffering from recurrent pelvic inflammatory diseases and eventually coming out with issues concerning infertility and all this stuff. You can go with the barrier method. Protect yourself when you want to do the do, and then prevent yourself from getting into this kind of mess. Alright, so this is what made it cast video. I'm sure you're able to understand these things. These are very technical and it's from technical people, but I'm sure some of you might go to the drug stores and things and take note of this and then be asking them to be giving medication. That's why I didn't actually add the doses to it, so that you still have to go to hospital for the doses to be given to you. Alright, thank you. Will come your way again.